Hello and welcome back to another episode of Advanced Human Gross Anatomy. Today, our ninth dissection, we will be talking about the male and female pelvis. We'll also be talking a bit about the bladder and the rectum. So let's get right to it here. We'll start with a review of the male pelvis. Here you can see a sagittal section. Here's a mid-sagittal section where things are cut a little bit more cleanly through the middle. But you can see the bladder here, the prostate gland, and the penis leaving. The portion of the urethra that exits the bladder going through initially the prostate gland is called the prostatic urethra, right here. That urethra will continue through the urogenital diaphragm and then is just considered the membranous urethra. It will then go into the corpus spongiosum of the penis and exit here. That is called the spongy urethra. So the urethra being quite long in the male, exiting the bladder, going through the prostate, through the urogenital diaphragm, through the corpus spongiosum of the penis before it exits down here. The prostate gland, about the size of a chestnut or a walnut, comes from the same embryologic tissue as the cervix in the females. Both of these glands are prone to developing cancer with age. The prostate gland causes more cancer deaths in males than any other next to lung cancer. So it's kind of a problematic gland as we age through here. Here's a different shot of that. So you can see the bladder urethra coming out through the prostatic urethra, the membranous urethra through the urogenital diaphragm, and then the spongy urethra continues through the corpus spongiosum of the penis. The vas deferens comes from the scrotum on the backside near the epididymis. Remember, the sperm cells get their maturation process complete in the epididymis, and then they exit through the vas deferens, which actually comes up, passes through the superficial inguinal ring, into the inguinal canal, through the deep inguinal ring, and then into the pelvis, crossing over the pubic bone here. It goes over the bladder, goes behind the ureter, and then enters the prostate gland right here. Where the vas deferens enters the prostate gland is where the seminal vesicle, this other gland right here, the seminal vesicle also enters the prostate gland. Where they join, it becomes what's called the ejaculatory duct as they enter the prostate gland together. So that is on the back side of the prostate gland, going over the bladder. So remember, we talked about this coming, the vas deferens going through the inguinal canal over the bladder. It's really taking a long course before it gets into the penis, before it exits during an ejaculation here, the sperm cells. You could see the vasectomies, when a male gets a sterilizing procedure called a vasectomy, the cutting and the not allowing sperm cells to go continuing their course through the vas deferens before they enter into the prostate gland through the ejaculatory duct. So that would stop a male from being able to reproduce simply by stopping the sperm cells from continuing their journey out the penis. So, but most of the fluid volume of semen actually comes from the seminal vesicles right through here on each side. So we'll be able to kind of see that. We'll identify those structures in a little bit. Right next to where that seminal vesicle is, as you continue, as you trace this vas deferens around there, you'll see a widened area here at the end of the vas deferens. That's called the ampulla as it enters into the prostate gland. So what I'd like you to do during today's dissection, on each side, take a blunt probe and just kind of clear out or sort through some of the fascia on the back side of the bladder to expose and identify these four structures here. So the vas deferens, here's the ampulla, and the seminal vesicle on each side. You should be able to identify one of each of those on each side. The prostate gland, you can't really see a good histological view of it here, but the prostate gland has tiny orifices that also secrete a fluid at ejaculation. About 10 to 30% of the volume of semen is produced by the prostate gland itself. About 60% produced by the seminal vesicles, and the remainder just from the vas deferens coming from the testicles here. So really, a male that has a vasectomy shouldn't notice much difference in the volume of semen being released at orgasm, because most of the volume of semen is coming from the seminal vesicles, and another larger degree to the from the prostate gland itself. The bulbourethral glands you can see right here on each side. Maybe a better view of it here. You can actually see a transverse section here, so you can see both sides. But the bulbourethral glands are found within the urogenital diaphragm here. They secrete and empty into the spongy urethra. And their job mainly works before the excitation phase of intercourse. During the excitation phase before orgasm, to coat the spongy urethra to neutralize the acidic environment that's produced by the urine. Remember that urine also goes through that spongy urethra, and so that's going to be much more acidic. And if the sperm cells were entering into that spongy urethra with that acidic environment, they might be compromised there. So the bulbourethral glands will help to prepare the urethra for the entrance of the semen as it goes through this same area. If we take another shot here of the urethra, we'll see this is a female pelvis and a male pelvis. They look fairly similar, except for the fact that the prostate gland is found in the male, not in the female. There's no prostate gland in the female. And here you can see how the urethra, as it exits the bladder, will just go straight down into the vestibule of the external genitalia and then exit the body. So it's very short, this urethra. The urethra on the male actually has to go, we talked about going through the prostate gland, through the membranous urethra, very similar to the female, but here is where it would exit it would make a 90-degree angle before it exits the body through the penis. So here's where it would exit the penis. You can see, let's go back to this shot here, where it leaves the bladder through the prostate, through the urogenital diaphragm, and then it turns. So instead of exiting straight out, it's going to actually make this 90-degree turn, go over the scrotum, and then exit out to the body in front. So you can see the length of the urethra much greater on the male than the female. This becomes important when we talk about urinary tract infections, yeast or bacteria that's coming up from the outside of the body. You can see how it has to go a very short distance in the female before it enters the bladder to become a problem. In the male, it has to go all the way through the penis into the through the prostate gland before it enters into the bladder. So what happens with the male is that typically any bacteria or things that are trying to get their way toward the bladder typically will get washed out during the next urination prior to it even getting a chance to enter into the bladder. So much more difficult for males to get a UTI, though it does happen. It's just much more uncommon because of the length of the urethra. You can see in this picture as well the bladder. There's 3 points here. These 2 points here where the ureters are entering from the kidneys, and the exit of the start of the urethra as it exits the bladder here. So the 2 entrances and the exit of the bladder, those 3 points make up a bit of a, you can see a triangle here. That's called the trigone of the bladder. And you can see from those points down, the wall of the bladder is much different. It's a smoother area here than the top portion of the bladder. So this area, the trigone, does not actually stretch when it fills. So the bladder has a tremendous capacity to expand and hold a volume of urine. I've been told by some nurses that when catheterizing patients, that they've taken a liter or more of urine out of the bladder. I mean, that's an enormous amount of volume to leave this organ. But that's where That's the stretching component of that is going to be on top here, the ability for the bladder to expand. Now, this was surprising to me a little when I learned this, that the ureters are way down here. They come in from the bottom. If I'm going to build a water container, I'm probably going to put the entrances of the material on the top and just allow gravity to fill this container up. But that's not how this works. Gravity really has nothing to do with filling the bladder. It's done by peristalsis. So coming from the ureters, pushing down, it just kind of fills by peristalsis the bladder from the bottom up. So as the bladder fills, though, you can see where the ureters are here, the entrances. As the bladder fills, it'll put pressure on here and kind of kink the entrances of those ureters, kind of like a valve. Kind of works like a valve. So the bladder won't keep expanding here. So the good news is you don't need to worry about your bladder actually exploding. Some people will say, oh my gosh, it feels like it's going to explode. It won't. You may lose some involuntary control of the internal urethral sphincter, and some voluntary control of your external urethral sphincter here and here. You might get a little bit that comes out, but if you can't find a place to void more appropriately, but the bladder itself won't keep expanding, so not to worry. Now let's talk a bit now about some pelvic vasculature. Now the aorta comes down from the abdominal cavity. You can see it coming down into the pelvic cavity right at about the level of L5. It splits and becomes the common iliac arteries here, which you can see on the right and the left. The common iliac arteries continue along the edge of the pelvic cavity by the pelvic brim, and then they split into here. You can see Netter has cut the external iliac artery on the left. Here he's maintained it on the left here. And then they split, the common iliac split into the external and the internal iliac arteries. Here's the external being cut and the internal, which we'll kind of trace down. The external iliac arteries go under the inguinal ligament into the thigh and become the femoral artery on each side, so going into the thigh. The internal iliac arteries, you can see here, supply the viscera of the pelvis. So that's what we're going to spend some time today in lecture and in lab trying to isolate this internal iliac artery on each side and identify some of its branches. So that's what we'll do now. Very often, but not always, but very often the first branch off of the internal iliac is going to be the umbilical artery. Right here, the umbilical artery will continue down, travels on each side, and it goes and supplies the top of the bladder. And that branches into the superior vesical artery, which goes right to supplies the blood to the top of the bladder, right here. But in the womb, this umbilical artery, you can see how it continues here. In the womb, this actually sends blood back to the placenta at birth. So, and at birth, this will kind of close down, seal up, and become the medial umbilical ligament. And you can see that it ascends up the inside of the abdominal cavity toward the umbilicus. So you should be able to find this medial umbilical ligament here as well. Okay. Now the second branch, very commonly off of the internal iliac, the second branch is often the obturator artery. This passes with the obturator nerve and vein out the obturator foramen. On the left side here, you can see Netter has it cut. You can see it here on the right side, where it goes out that obturator foramen with the obturator artery. I'm sorry, the obturator vein and nerve, and that's going to be an easy way to identify that obturator artery as it exits the obturator foramen. The inferior vesical artery, here going toward the bottom of the bladder. You can see here toward the bottom of the bladder. It will also send a branch in the male to the prostate gland. The prostatic arteries, prostate branches here from that inferior vesical artery. In the female, which we'll learn in a bit here, actually has a couple of branches off the internal iliac. One called the vaginal artery, and one called the uterine artery, going to the the vagina and the uterus in the female. Obviously not shown on this picture here. The internal pudendal artery, we've spent some time learning in the past how it will leave the greater sciatic foramen with the sciatic nerve. It will loop around the ischial spine and enter into the lesser sciatic foramen, which before entering that pudendal canal. Remember Alcock's canal down here in that ischial rectal fossa? So this is going to give branches into the inferior rectal branches, which are going to be down here to help supply the perineum. We saw this on a previous dissection from a different view. It will also give branches toward in the male, it will give branches toward the scrotum and the penis. In the female, to the labia and the clitoris off of that internal pudendal artery. Here you can see this inferior gluteal artery right here coming off back here from where the internal pudendal artery branches. It will also continue on to the inferior gluteal, and that's going to supply the gluteus maximus with nutrition right here. And on the posterior division here, you'll see the superior gluteal arteries, and the artery, and that's going to one on each side, obviously, but that's going to supply the gluteus medius and the gluteus minimus with blood flow. Now, the order as it comes off of this internal iliac will vary, so you don't just memorize 1, 2, 3, 4 goes okay. It goes umbilical, obturator. It may not do that. That does vary in some cases. So you really will have to trace them down to kind of find where they're going to be able to correctly identify them. So we'll spend some time doing that in lab. Now, venous drainage of these areas, there often will be a vein that follows a corresponding artery, but it'll also form these plexuses. It'll also form just these bundles of venous return, these plexuses of veins that come back in this area. The vesicle or the prostatic venous plexus flows into a rectal venous plexus in front of the rectum. These veins can be confusing to identify. You'll see that there's quite a bit of them. There's a lot that just kind of bundle together. So we can remove some of these veins in the dissection if you wish, but try to preserve the arteries. I want you to be able to trace down from that internal iliac and preserve the arteries as they come down. But the veins, we're not going to be able. It's a little bit trickier. We're not going to quiz on that. So if you'd like, just to make it a little more clean for the arterial dissection, you can remove those. These plexuses will often associate with the plexus of veins around the spinal cord as it comes up, and that travels all the way up to the cranium, which does make it possible in some cases for prostate cancer to travel, to metastasize all the way up to the brain. So that can be a dangerous thing there. So those plexuses of veins, you'll be able to notice. Now let's look at the rectum. The rectum here we've talked about in the past, but let's just review this as well. You can see the transverse folds here, kind of as it folds in like this on itself. It causes it to be a bit compartmentalized, the rectum. It does have stretch receptors in the walls of the rectum here that will send signals to the spinal cord that send a reflex back that causes a muscle contraction when it gets full. When this area is full with fecal matter, those signals will kind of allow for a warning when the system is full. So you can voluntarily stop the release of materials here through the external anal sphincter, as well as the levator ani. Remember those muscles we talked about coming down here. The puborectalis, particularly, that will kind of kink the rectum down here and not allow the release of material until it's more socially appropriate to do so. Finding a place to do that. You can see how during infancy, the need for diapers. These muscles aren't that you lose control. You don't have control yet of these muscles voluntarily, and so when stretch receptors get activated in the wall here, it just material will just come out. So you can see the need for a diaper in an infant. Next to there are veins, you can see here, next to the anal columns. You can see these anal columns at the distal end of the rectum here. These can become varicose with straining, can cause valve damage here. So you might have varicose veins. We call those hemorrhoids when they happen in the anal canal here, the hemorrhoids through the veins here. And you can see these anal columns here on the ends here. They have a membrane that at the end of them that forms a sinus. You can see there's little spaces, little grooves between the columns at the distal end, at the anal canal here. And these are where the anal glands are. The anal glands secrete a mucus. It does have an odor. As a bowel is pushed through this area, it compresses these columns and squeezes this mucus out to lubricate the bowel, allowing it to exit more easily. So you can see where that goes there. Now, within the rectum, this is also a site of varicosities that we've talked about with those veins on each side. So you could have just by straining, like I said, you're trying to get bowel to release from this area, you might damage some of those valves and get to varicosities. But it can also be a site, we talked about this previously with portal hypertension by cirrhosis or damage of the liver can also cause these areas to have varicosities as well. So hemorrhoids can actually happen through an increase in blood pressure through the portal system. We talked about earlier too that the other areas where that can happen is you might find some bleeding in the esophagus and in the stomach, and that's a real red flag. That's a danger zone there. But you might also get it in the anal canal. Now, the danger here is that it might actually just get passed off as hemorrhoids and not actually be seen as the red flag that it is coming from the liver damage. So that's there. Let's talk about the sacral plexus. You can see these plexuses of these nerves entering or exiting the anterior sacral foramina here on each side. The lumbosacral trunk are just fibers from the lumbar plexus that contribute to that sacral plexus. You can see how they're coming down in through here. The majority of the sacral plexus forms the sciatic nerve. The sciatic nerve supplies the posterior thigh, the entire leg, and foot. There's a branch off the femoral nerve that will supply the medial leg with sensation superficially, but the majority of that posterior thigh and entire leg and foot are supplied by the sciatic nerve. So L4, L5, S1, 2, 3, sciatic nerve coming down. It's a massive nerve, can't miss it. The sympathetic trunk, you can see here, and we've talked about this quite a bit, coming down, extends down all the way to the sacrum, to ganglion impar down here at the very end. Lays medial, you can see it's medial to on each side where the nerves exit the anterior sacral foramina here, right there. So it's medial to that. Remember we talked about branches up here in the lumbar area called the lumbar splanchnics, get involved in the plexus around the aorta. And then branches from the sacrum, we call the pelvic splanchnics, but the sacral branches here, remember, are parasympathetic autonomics. So these are the rest, digest, heal contributions, along with those from the cranium. But they also contribute to that plexus around the aorta in the abdomen. And so it's hard to be able to differentiate which is which, obviously, but just so you know that the sympathetic trunk does come all the way down into here. Now, the lymphatic drainage components here, when lymph, as it drains, you'll have nodes around the genital areas and in the inguinal canal. These are the superficial nodes through these areas. They mainly the lymphatics to the genitals as they come down through here, the external genitalia. They can also get inflamed with infection from the legs, as infection comes up from the lower extremities, but mostly from the genitals here. These superficial nodes are easily palpated by a physician to check for possible infections on the outside through here. There are deep inguinal nodes here as well. deep internal nodes. So superficial, these inguinal nodes here, and then the deep internal nodes coming up here. These are from the testes and the prostate are going to drain up into the abdomen. They drain towards nodes around the aorta, which you can see up here. The female pelvis is similar, having the external genitalia going into these external nodes, and the internal nodes going towards draining the internal organs, going towards the aortic nodes up into here. So you can see why dangerous for the prostate. Cancers or disease processes from the prostate going up into these nodes that go up in more into the abdominal cavity, much more dangerous that way for metastasis. Let's look a review now of the female pelvis as it compares to the male pelvis. So you can see, remember we've seen this picture before looking at the bones of the pelvis. This anterior to posterior diameter here. It's called the conjugate diameter, measured by an obstetrician. You can see it's very similar to the male anterior-posterior, the conjugate diameter here, very similar. This will be measured by an obstetrician to determine suitability for natural childbirth. The more important one here is the transverse diameter. This is what you can really see as the big difference between the male and the female pelvis. Is transverse diameter might cause an OB to recommend a C-section delivery versus a vaginal birth if that area is not quite as big. The pelvic inlet, you can see here this funnel coming down at the pelvic brim, where this false pelvis on each side as it enters the true pelvis at the pelvic brim, and the pelvic outlet would be down here where a baby would exit. So you should be able to notice that here. If we look now at the female pelvis, the urethra exiting the bladder. Here you can see the bladder. Here's across a midsection here. When you're finding the bladder is always, both males and females, immediately behind the pubic symphysis. So you should be able to find that very easily here. So the pubic symphysis, the organ right behind it, has got to be the bladder right there. So let's look at the mid-sagittal section here. The bladder, as it exits, the urethra exits the bladder rather down into the vestibule of the female external genitalia here. The vagina being immediately behind the bladder and the urethra right here coming up. The uterus sits right on top, superior to the urinary bladder. This is kind of unfair, I think. When a baby is filling the space and grows, it pushes straight down. Guess where it is? Right on top of the bladder. So females will often talk about having more frequent urinations during pregnancy simply because the baby is literally on top of their bladder. The fornix, which you can see here at the top of the vagina. I'll mention this because it's sometimes used as a site for a diaphragm, which is a prophylactic device for birth control, which will close off the entrance to the uterus during intercourse. So sperm are unable to penetrate through the cervix and into the uterus, into the fallopian tubes, and where they can eventually fertilize that egg. So I can stop there. Let's see, the bladder. We've talked about the exit of the urethra here. Let's change. Here we've talked about this, the urethra, the female pelvis here, the male pelvis. Let's go to this section here where you can see this forceps here. Netter is drawn holding up the uterus in cross section here. So let's see this coronal view. The uterus here, you can see the vagina coming up. The fornix would be right here as the entrance to the cervix of the uterus. You can see the levator ani muscles on each side, here and here, coming down. The ischial-rectal fossa, which we've talked about in the past with the Alcock's canal. So you should be able to kind of notice those things here and here. Let's see, the bulb of the vestibule. Netter has that in blue, kind of this purplish here. The bulb, this is erectile tissue lateral to the vaginal opening on each side. The bulbal spongiosus is the musculature within the bulb of the vestibule on each side. The vestibule is this area where it has the entrance of the vagina. It's the area between the labia minora. So the labia minora on the outsides here, labia majora on the outsides of that. In development, the labia majora would be fused to make the scrotum in the male. But where the labia minora come together at the bottom, this is the vestibule right through here, this area inside. Again, erectile tissue making up this area, more prominent during sexual arousal or excitement in through that area. Let's change views here to look at the anterior portion of that vestibule where the labia minora come together. At the front end, on the anterior aspect, is going to be the clitoris up on top. The clitoris, analogous to the male penis, has a same kind of language here. Remember, the crura comes up here, the cruiform on each side making a V shape anterior to the clitoris, and that folds at right angles coming down under the skin, so they form a prepuce here. Same language as the male penis. And then they come together to form the glands of the clitoris here, the body here, back slightly posterior to the crura. This gets thought of as the place where sexual excitement happens in the female, and that does. It has a lot of nerve endings, but there are nerve endings throughout the vestibule in the female for sexual excitement, but the clitoris' main function for stimulation during sexual excitement here. Vestibular glands, mainly the clitoris here and the labia minora, engorge with blood during sexual excitement. So females, it's told, do get erections too, just like the male, but obviously much less obvious. In your practice, you may come across people who have had a female circumcision, which is kind of I think it's kind of a tragic procedure. I guess my familiarity with it is not that great, but sometimes practiced in Asian or African cultures where part of the labia minora and the clitoris are removed, possibly for the purpose of decreasing pleasure during sex, for religious or cultural rationale. I'm not very familiar with it, but you may come across that where some of the labia minora and clitoris have been removed. The mons pubis on top here, a hair-covered area at the anterior portion of the pelvis, has a fat pad prior to the pubic symphysis. The males have this too, but since this is where the penis exits, we don't really talk about the mons pubis much in the male genitalia. Here you can see, we'll talk about that pudendal nerve again, coming down as it enters into Alcock's canal here, but exits with the sciatic nerve from the greater sciatic foramen, again looping around that ischial spine, entering back into the lesser sciatic foramen, branches here into these inferior rectal nerves. You can see here, or inferior anal nerves coming toward the rectum. And the anus also gives posterior labial branches coming up here into the labia minora and majora. Also has branches that go anterior toward the clitoris as well. Let's see about this picture. Now, we'll talk about the perineal body, or the central tendon of the perineum. Here you can see in the male, and here you can see the female perineum, the central tendon. This is where it's kind of a congregation of muscle attachment sites. So the reason this is so important here, the central tendon, is because muscles come from this area and go in all directions. So you can see the bulbospongiosus coming here, going into the penis in the male, and the female coming around the vestibule here on each side. The superficial transverse perineal muscles, and then there are deep transverse perineal muscles on each side, both male and female. Remember, the deep ones are inside those two layers of the urogenital diaphragm. So they're superficial to the pelvic diaphragm, but they're within the urogenital diaphragm. And then you have the external anal sphincter on each side coming around. The male would be right here, the external anal sphincter. So you can see how it's pulling really from the back here to the external anal sphincter. It's pulling laterally for the superficial and deep transverse perineal muscles, and it's pulling anteriorly with the bulbospongiosus. So you can see this central tendon of the perineum, where the perineal body really does have a lot of things coming around to it. So you can see why that's so important. A couple other muscles here, the ischiocavernosus muscle on each side here for the male and the female. You can see here. The female, it attaches to the skin, kind of adjacent to the clitoris on each side, the ischiocavernosus. On the male, it actually goes into the penis on each side and can help with elevating the erect penis. So erectile tissue kind of coming in through there. The bulb of the vestibule, let's find a better shot of that here. Remember, we talked about this a little bit with a different section of it. Coronal view. Here's just a transverse view. You can see coming straight inferiorly. Netter's shaded this the bulb of the vestibule in blue. This is not shown on this side, but it is on both sides here. This erectile tissue at the base of the labia minora, right here, goes anterior toward the clitoris and folds, and it really gets to the body of the clitoris on the top portion. So again, that female erection with the vestibule kind of filling and gorging with blood during sexual excitement. The greater vestibular glands, Bartholin's glands here on either side. It's not shown on the right side, but on the left side you can see it here. These are at the base of the bulb of the vestibule. They secrete a lubricating fluid that will fill the vestibule right here. It kind of a preparation prior to penetration during sexual excitement in the female. Also have other glands doing the same thing around the labia minora. Secreting mucus in preparation to accommodate the penis during intercourse. So before intercourse, you want this area to be well prepared and lubricated. This is just one of the many tragedies that can occur during rape. Is that if there's no sexual excitement, if this isn't a desired activity by the female, if there's no sexual excitement, there's no preparatory secretions in this area, and you can injure this area as well. So you may be involved in helping women who are in need of that kind of care as well after such a tragic event. Just what can happen. The external urethral sphincter coming up on top here, anterior, which is kind of this anterior continuation. That might be the best shot I've got of it here. Kind of an anterior continuation of that deep transverse perineal muscle. You can see there's to stop the flow of urine. So during a Kegel exercise, that would engage and stop the flow of urine, those deep transverse perineal muscles. The bulbospongiosus we've talked about in the female would assist with grasping the penis during intercourse. In the male, the bulbospongiosus muscle would help with expelling urine and semen from the spongy urethra when contracted in the bulb of the penis. So the bulbospongiosus. Let's see if I can find a better picture of that quick. Well, here you can see it there through the bulb of the penis and on the sides here for the female. Okay, let's change gears a little bit now and talk about the female pelvis in this sense, where there's the vesicouterine pouch. So this broad ligament formed by the perineum coming down and coming over the uterus will kind of create these two pouches, one in front and one in back here. So this vesicouterine pouch, vesico refers to bladder, so it's going to be on top of the bladder but over the uterus. This broad ligament comes down, so you can see this pouch kind of in front of right here, between the uterus and the top of the bladder. There's also a rectouterine pouch between the uterus and the bladder and the rectum back here, which you can see this little area where that broad ligament creates a little bit of a pouch. Neither of these are found in the male, obviously, because they are found because they cover the uterus. The round ligament of the uterus, you can kind of see here, you can kind of see that round ligament of the uterus. I think this is a better view of it here. This is a transverse section coming straight down, but you can see the round ligament here coming this way, coursing, going sideways from the uterus. Just like in the gubernaculum testes in the male, when it's pulling the testes from the abdominal cavity, the female also has the descent of the ovaries as it comes down. So the gubernaculum will pull the ovaries into the pelvic cavity and become the round ligament here as it comes down. So that round ligament attaches into the deep inguinal ring to help hold the uterus in place. But unlike the male, where it pulls the testes down with it into that inguinal ring, down into the scrotum, retroperitoneally goes down into that inguinal ring, the female just leaves the ovaries in the pelvic cavity, and that gubernaculum just connects the uterus then to the anterior abdominal wall. So you can see that. Here you can see the round ligament we talked about already, the ovarian ligament, holding the ovary to the uterus on each side. You can see the ovarian ligament right here. The broad ligament, just part of that peritoneum covering from above, because the peritoneum will cover from above and cover the uterus. You can see it here, this broad ligament right there. The fallopian tubes coming off of the uterus as they come around, and they don't actually attach, they don't actually connect to the ovaries themselves on each side. They just kind of sit here. So this is one of the miracles of life here, is that when the ovary releases an ovum during ovulation, it just gets released, believe it or not, into the pelvic cavity. And then miraculously, you think, well, wouldn't it be lost forever? But it doesn't. It finds its way into the fallopian tube each month. That's just amazing to me how it can do that. These suspensory ligaments, you can see it more on the right side here. Suspensory ligaments, as the ovary descends from the abdominal cavity, the vessels and nerves get dragged along and pulled, that pull the fascia with them, and that kind of forms this suspensory ligament on each side, holding the ovary to the abdominal wall, to the pelvic wall there. From the ovary, let's see, for stabilization, we'll kind of hold it back like that. The ovaries are also enveloped within a bit of that broad ligament. You can see here that broad ligament kind of covers the uterus, but it also covers a bit of the ovaries as well. So a word we use for that is the mesovarium, which is part of the broad ligament that envelops the ovaries there. And I think that's probably enough of this. We'll do one more kind of review of the female pelvis next time. Well, here, let's just real quick take a look here. You can see the round ligament coming this way, the fallopian tubes coming around, the ovarian ligament, the suspensory ligaments would hold the ovary to the body wall back here, coming down. Yeah. All right. I hope you learned something. I hope this was interesting, and I look forward to seeing you in lab, and we'll take it from there. Thanks for your time. Have a great day.